So so really what I'm going to focus in on is smoking and cancer and smoking and depression. These are two clinical populations that I like to refer to as high tobacco burden populations. So they have higher smoking rates. They have a harder time quitting smoking. They don't have access to treatments. So part of what I think is involved in improving the treatment for these clinical populations is increasing access. And they tend to live and work in environments that are more easier to smoke in. So they really are these high burden sort of populations that we need to focus on if we're going to reduce the population prevalence. And certainly it's the case here in England, in the UK, it's the case in the United States. And so what I'll sort of skip is the sort of the basics, which show improvements in addressing tobacco use and dependence at the population level in the US, the UK, in Australia. But what we've seen recently is a stability of quit rates. And so these are the populations that increasingly are the ones who are smoking and who are dependent on tobacco. So before we get too much further into it, I want to thank the GW4 for funding this trip. I spent last week at the University of Exeter, which was a ball with Lee Hogarth, and it's great to be here now. So I think the keys, certainly we need to develop more effective medications. That's a harder process to engage in. So I think a more sort of manageable goal is to increase the efficacy and the reach, as I mentioned, of treatments that we know to be effective. There's not as much attention on this as there should be. And then the second, and this relates to the focus on clinical populations and other high burden populations. We need to identify both existing treatments and then develop novel treatments that address or target the factors that maintain dependence and smoking in these populations. And so what I'm going to take you through is a series of clinical trials that we've either done or we're in the midst of, and one that we're actually now just beginning, which try and improve treatment by addressing these keys. So just as a sort of the context, I want to run through what we know about the efficacy of existing treatments. These are data out of our public health service guideline. We can see that with increasing contact, behavioral treatment achieves about a 22% abstinence rate. With medication, most effective medication is Varenicline. These are a bit old now, but certainly I think this can still be said about Varenicline. And then we have all of the other medications that achieve more or less comparable rates. And I'm sure you've been following the sort of the trends in Varenicline use. Unfortunately, the use is down, prescribing is down, and this is one of the problems that we have in our trials, and that is getting providers to prescribe it or to refer people to our treatment programs because of the concern about neuropsychiatric side effects. Hopefully, at least in the U.S., the black box warning will be lifted soon. There's going to be some data probably in the next 6 months showing efficacy and safety in a very large population of smokers with psychopathology. So the ones that you would expect to be the most vulnerable. And then with combination medication, we get the best outcomes with patch and gum, giving us about a 36% abstinence rate. So now on to what I think are the keys. So our first, this is a study that we've recently completed and published on. And here what we wanted to do is there were a couple of things. We wanted to increase access, so we really opened up the eligibility requirements. The only psychiatric conditions that we didn't allow were smokers who had bipolar disorder or psychotic disorder. But otherwise, we really opened it up, and the goal was to increase access. And we even a standard in trials has been to require 10 cigarettes or more for entry. We lowered that down to any amount of daily smoking. The other, so what we did in the study is to say, okay, and this is it's not a new idea, but it hasn't gotten the attention that it really deserves. We said, okay, tobacco dependence is chronic. Let's treat it like a chronic disorder. So part of that requires longer-term treatment. We had data going into this grant application showing that 6 months of treatment was more effective than standard duration treatment. Here the question was, would keeping someone on patch for a year improve outcomes over 6 months? So the question is, how long does a person really need to be on treatment to benefit? And some surprising results. Just to point out here, we sort of achieved the variability in the population that we wanted. Almost 20% had a history of depression. And this is a population for a long time that's been excluded from most clinical trials. And I think the reason that they've been excluded and other smokers with psychopathology have been excluded is because they're the hardest to treat. And for years, most of the studies were funded by pharma. So we had a really good population, and here are the results. So no difference at 8 weeks. Everybody got behavior therapy for a year. So 8 weeks of treatment, 6 months, and then a year of patch treatment, behavior treatment for everyone for the entire year. They had an advantage of 6 of the standard or the extended duration treatment over standard duration at 6 months. No similar pattern at 1 year, but the effect goes away. What was surprising is that this group that was maintained for a whole year did worse than those who were only on medication for 6 months. And part of what we realized when we were going through the data is that there was a big drop-off between 6 months and 1 year in patches. We just had a harder time, and it was especially so for that maintenance duration patch. So 6 months is more effective than standard duration. And these data speak to the patch use guidelines in the U.S. and I believe here in England as well, which is patients are recommended to use patch up to 12 weeks and only after 12 weeks if you're under the supervision of a physician. So these data show that it's probably not warranted. The safety was no different between 1 year and 6 months, and that's the other important point. So, any questions about this data? So now, this is a study that we're in the midst of doing, and this is a study that's targeting smokers with cancer. Lots of reasons why smokers with cancer need to quit, more than the average smoker. Smoking interferes with cancer treatment. It interferes with decreases their quality of life. When they quit smoking, the efficacy of cancer treatment improves and their survival improves. Part of what in this study we were testing extended duration Varenicline, similar to the model in this trial that I showed you. But here we chose Varenicline because of the effects that we were expecting on some of the factors that seem to be driving and maintaining smoking in this population. They show an unusual relapse, whereas most smokers relapse early on. The relapse curves for smokers with cancer are very different, and that is protracted, in that the rates go up after 2 months. There's a lot of emotional distress and cognitive impairment. And Varenicline has been shown in basic studies as well as some human laboratory studies and clinical trials to have effects on those factors. So we thought Varenicline might be ideal, and then if we provide it for a longer duration of time, we might be able to address the protracted relapse. So this is our, I'll take you through the design and then some of our open label results at 12 weeks. So they're randomized to standard duration Varenicline, 12 weeks, or to extended duration, which is 6 months. At 12 weeks, they're randomized to placebo, and I think we have 7 behavioral sessions over that time period, and then we're going to follow them up for another 6 months. Our target sample is 374, which would probably be twice the sample size of current studies. So, and part of how we've gone about trying to do clinical trials with this population or these populations is to team up. So, in all of these studies that I'm presenting on, we have a site in Chicago, and we have a site in Philadelphia, and together we've been able to do quite well in achieving the sample size. And I hope the same is the case here. We've also, to try and get the sample size, we've opened it up to all tumor types. And we've also opened it up to anyone who has a diagnosis through 5 years, so survivors. I'm not going to spend too much time on this, but we are quite proud of the flow and what we've achieved so far. So with the 427 eligibility screens, and that took a ton of effort, and part of the problem is getting physicians and also patients to want to sign up for a treatment that involves Varenicline, so we've done a lot of education. But of those 427, we've had 30% randomized or enrolled and randomized. And right now we have a sample of 124. We've had a few withdrawals, which has been good news. And I have to say that the most surprising bit about this study is that high treatment completion rates. So we have in a lot of the maintenance therapy study that I showed you, we had a completion rate of about 70%. In this study, with patients who are, a lot of them are going through chemotherapy, we have almost an 85% completion rate in this session. So we're quite pleased and also surprised about that. This is our sample. So we have 42% who are staged in treatment. So a lot of these people are really going through a lot, and it's again it's surprising that they continue to invest their time in the project, given everything they have going on. We don't have as much diversity, unfortunately, in our sample. It's a sort of limitation in cancer trials in general. So here's our abstinence rate at 12 weeks. So this is the time everybody's on Varenicline, 48%, which rivals the abstinence rates that we're seeing early on in the Varenicline trials. So we'll see if that holds, but certainly it tells us that we're on the right track with this intervention. This would be the first study to actually focus on Varenicline as a treatment. The other really sort of nice aspect to this is that it's really safe. We've had 31 AEs, with only one probably related to medication in our treatment. So right now it seems to be at least effective after 12 weeks, and more importantly, safe. So now will be, I think we have some really good variability to see whether if we extend treatment over 6 months, we can sort of reduce that relapse rate that we've seen in other studies of cancer patients. So now I want to switch to a study that we've just opened up to recruitment in the last week, and that is a treatment of behavioral activation and Varenicline for smokers with major depression. So another population that falls into the high burden population, and one of the benefits of quitting for smokers with depression that we've realized through a recent meta-analysis is that the mood improves. And it's been estimated that the mood improves at a magnitude of which you'd see with antidepressant treatment. So quite a boost from, at least from the clinical literature, showing mood-enhancing effects of quitting smoking. So have any of you studied behavioral activation, or is there other studies going on here with behavioral activation? So behavioral activation it's really the sort of behavioral core of CBT. And it's the piece of CBT that accounts for most of the improvement that we see in depression treatment. And here we think we chose this because of the sort of the risk profile that we see with depression. Anhedonia and smoking rewards seem to predict failure in quitting smoking. They have severe craving and withdrawal, and there's a memory and attention impairment in depression itself. So we think that certainly DA will affect anhedonia and smoking reward. And in a minute, I'll take you through exactly how we think that might work. But really, the fundamental purpose of DA is to get people doing things that are enjoyable. And very simply, if they're doing things that are enjoyable, we have a chance of decreasing smoking, which for most has been really the only source of pleasure. We started, this is a project that was 2 years in the making, at least from getting funding, but we really had to start fresh, and there's been no sort of model of how depression or how smoking functions for depressed smokers. So part of where we started is to sort of, how does smoking function for this population? Because if we know how it functions, then we have a sort of a lead on developing an intervention that can treat dependence. And here's simply sort of how we thought it might work. Smoking would increase capacity, increases cognitive function, which is a increasingly we're realizing a core deficit in depression. That in turn reinforces smoking behavior through the high reward value. And then on the opposite side, I mentioned to you the severe withdrawal and craving that we experience. So certainly that's part of it. That's the case with every smoker. What I think is unique about this population is sort of the fact that these withdrawal symptoms are very similar to their psychiatric symptoms. And one of the things that you hear from smokers who have depression is a concern about their psychiatric condition coming back, or they're losing the progress that they've made. So what I think happens, and we're trying to figure out how to actually test this experimentally, but what I think happens is that that withdrawal, those symptoms mimic their depression and sort of trigger that concern. And that's part of what gets them going back to smoking. That's sort of what also feeds into provider concerns that, if my patient who has depression quits, they're going to relapse back to the depression. When in fact, the clinical data that we have shows that their mood actually improves. So we started with this model of smoking behavior, and I'd be happy to come back to that. This was sort of the part of, we had the model, we thought, okay, this is maybe how smoking is functioning. We had to figure out, well, which treatments do we use? And so we've accumulated a database now that has probably about 15,000 individual level participants in it. 30% have a history of depression, and we were able to accumulate that sample because of the need to exclude people with current major depression. So trials for going back to 88 would do a diagnostic assessment because they wanted to exclude people with current depression. But then it also provided data on smokers who have a history of depression. And we've been accumulating these data over time. We thought this is perfect. Let's see what treatments might benefit smokers with past depression, and as a way to figure out what we should be testing in those with current depression. So what we did, we spent, and I think Marcus, I was probably coding these data when you and I were in Miami. But I spent time recoding every treatment arm in this study according to whether they received behavioral treatment, CBT mood management. This has really been the intervention that people have applied to depression. It's been very simply thought that, okay, if they're smoking because they have depression, right? Smoking's making the depression better, so let's make them feel better and they'll smoke less. So lots of studies on CBT mood management, which have shown some success in the short term, as I'll show you. We coded on medication, antidepressant or not. And then what we were interested in here is we wanted to know which factors, sort of which interventions predicted success in quitting. We looked at short-term abstinence, and these were the main factors. So CBT mood management predicted short-term abstinence, nicotine replacement, and Varenicline. Part of the limitation here is that we had only a couple of studies, but they offered a large sample size. And then long-term, we had some nicotine replacement went away. Really had no other effects except for depressive medication, primarily, and then Varenicline again was the another predictor. So it seems to be the case that it seemed to be at that point that Varenicline was the medication we should choose. And I had, we lost the CBT mood management aspect. And I had been involved in several of the studies as a therapist. And my reaction as a therapist was, I don't know, does anybody do depression treatment? Okay. So my experience with trying to get people to look at their thinking and how their thinking affects their smoking was that it was really hard to get it across to patients. And so we thought we needed an alternative behavioral approach that was just simpler to administer. And here, and that's where behavioral activation came in. So it's been thought to be simpler to administer in that you don't have to have a PhD delivering it. It's certainly been thought to be easier for patients to get and to use. It directly aligned with sort of how we thought smoking was functioning. And again, I mentioned to you how we think it works. So here was our sort of model of how we thought these interventions might work together. So behavioral activation, we thought would increase positive reinforcers, particularly reinforcers that don't go along with the smoking. So physical activity, for example. We also expected it to increase abdominal capacity, and then decrease cigarette reward value to affect cessation. We know Varenicline has effects on subjective pleasure that's gained from smoking. So we are expecting an effect there, and then there's the effect on cognitive performance that we're expecting, which we also think will decrease cigarette reward value and craving and withdrawal. So this is sort of, I'm happy to go over this a little bit later, but this is how we're thinking that these two treatments might affect abstinence. This is our study design for this trial. We're targeting a sample of almost 600. Huge undertaking, and I underestimated. I've been doing drug studies for a while. I underestimated what it took to get a new behavioral intervention up and running. But this study is going to involve smokers with not only current but recent. We've extended it to 2 years, within 2 years of having a diagnosis. And all of the participants will have at least mild symptoms. It's part of how we think it might be working. So in this case, we're randomized to standard treatment or behavioral activation, which is integrated into standard treatment, and then placebo or Varenicline, 12 weeks of treatment, 8 sessions of behavioral intervention, either standard or behavioral activation, and then we have 6 months of follow-up. This is what we're predicting in terms of the outcomes. So we expect that the combination of Varenicline and behavioral activation is going to produce about a 40% abstinence rate. We'll see if that holds. If we are able to achieve the sample size, that would be huge success. If we're able to increase abstinence to this magnitude, that would be even better. So just to kind of wrap up, I've taken you very quickly through these studies. We really need to focus on these clinical populations or high-burden populations if we're going to make the kind of progress that we need to at the population level. And these are what I think are some of the keys. It's increasing the efficacy of existing interventions, identifying targeted interventions, and part of that it's going to be possible if we can demonstrate the safety of these clinical populations, which really seems to be a major concern. And then another area that I'm starting to focus on is how to increase reach, access, also engagement, and then use of all of these interventions that we know work. And so I've now turning to projects that involve low-income populations who are connected with a healthcare network that provides care for uninsured and underinsured patients. And trying to very it's sort of simple in principle, but we're trying to link the electronic health record of this large network. This one has about 40,000 patients in it around Chicago, directly with the quit line. So we can have, we can get people to the quit line, our state quit line in Illinois, and we can get outcomes fed back to the providers who actually care for the patients. But that kind of effort has its own issues, and so I've spent 3 years now developing the sort of the components of this kind of intervention, and our state has decided that they're going to use all of the money that they get from the tobacco settlement and put it towards other aspects of the budget. They're going to close down our quit line, which is horrible. It's horrible for a lot of reasons, but it's certainly going to get in the way of us increasing access to people who don't have access. So I want to just point out we have a sort of huge team that have been working on these various projects. People from Northwestern, from Penn, some from Brown, Nara from Legacy, and Lee Hogarth, who many of you may know from Exeter, who's been really helpful on helping us sort of establish what we think are the sort of mechanisms that might be affected by the treatment of depression. And then these studies have been funded by NIDA and NCI, and certainly wouldn't be able to do them without the kind of funding that they provide, even if it's less than it ever was before. I mean, it's really tough starting out with these trials and then getting a 20% cut off the bat. I don't know if this happened here. Yeah, so it's really tough to sort of propose something that one is really excited about, thinks has a lot of potential, and then end up with 20% less funding, and every year the funding goes down. So, but nevertheless, we wouldn't be able to do it without the funders. So, happy to take any questions you have or any discussion about some of the stuff you're doing, whatever. Yeah, thanks.